HLT too.
Yeah, exactly.
Are you around in a little bit?
If I'm not, either I'll be here or in the mouse room, but yeah,
Okay.
I will be in.
Because I have a new idea I wanted this
Oh, okay.
for a grant.
Mouse room.
So you guys do what TBD stood for.
Yeah. I was gonna just put health and I was like, you know what, I'm just gonna leave it, but no one knows what it.
All right, thanks, guys. Have a good morning.
We were gonna call it healthcare or something, I don't know. Cause they're monitoring.
Are you not
Trying
allowed
to
to
use
say
myself.
disparity?
Stuff, which is racial disparities and chronic kidney disease. I mean, there's obviously sex disparities, there's all different kinds of stuff that's been specifically focused is more on the racial disparities. Okay. All right, so why do we use CKD? So it's really interesting. When I was doing my master's in public health, oh my God, many years ago, and I was a renal fellow when I started it. And all of a sudden, like, nobody talks about healthcare disparities, and then I'm in my master's class, and all of a sudden they're like, end-stage kidney disease is one of the most dramatic examples. Like, you know, because it was just something that we weren't ever taught, and then so all of a sudden, and so we've been really incorporating it since that time, which was a long time ago. Because like there's so many different things, and as I'll show you, it's not just one thing, right? This is completely multifactorial, there's lots of things that go into it, but there's no doubt they exist. And this is like the quote I always like to start with from Dr. Martin Luther King Jr. Because I believe this is very true, you know, when you start thinking about things that have happened in this country, and now it feels like we're doomed to repeat because we're not looking at stuff. So let's start with a case. That out of the way. So 60-year-old Black man with a history of hypertension is coming to establish care. He last saw a physician 3 years ago at an urgent care center and he had a foot injury. 5 years prior to that, he said, you know, told he had hypertension. He was started on some medication And a followed visit blood pressure was normal, but now he's not taking any meds. And he was recently able to get healthcare insurance, so that's why he's coming back. Family history of some diabetes and hypertension. As you can see, blood pressure is elevated, he's mildly obese, and he's got some lower extremity edema. And unfortunately, you get his labs, and his creatinine is 3.2, giving it a GFR of 24, bicarb 19. UA's got some protein, no blood, and hemoglobin's pretty low. It's kind of a typical stage 4 when we start seeing them, and kind of unfortunate. So what do you guys think compared to a white man of the same age, this patient's risk of progressing to end-stage kidney disease is lower, the same, or higher? Higher, right? What about in getting a kidney transplant, even if all things are equal, insurance, everything, comorbidities? Lower, yeah. And so when you start hearing like health disparities, and this is like, I'm sure these definitions are gonna change and whether they exist, but it's basically the differences in health status among groups. And so they exist in everything. This is not unique to kidney disease. Any kind of chronic disease you find, you're gonna see these. They're complex, they're at every level. So you're gonna find them at local, national, state, everything. And so like, what can we really change? Probably more of the local things, if you will. And of course, end-stage kidney disease is super dramatic. And the reason I say this, I'll show you in a second. So I'm not trying to convince anyone of this, but race is truly like a social, not a biological construct, because there's actually more variation within a race, sometimes at levels of DNA than between races, and they're not real in the biological sense. But our perception of race has like real consequences on others. And so there's lots of different quotes, but like really, I mean, there's like one human race, and are we really different? And then everyone always brings up like Obama, right? Well, what's his race? Like he's got all these different, you know, if you start thinking about that, and it's really how people self-identify. Like I'm self, but does that mean their DNA or something is different? And as we'll show you, like, yes, there's APOL1, but that's not just in Black Americans or Black individuals, that's in people who are Hispanic that they're finding. And so it's not something, it's more of like, oh, do you know where your ancestors might have come from that maybe you're predisposed to something, but it's not necessarily race itself. So to me, that's more of a social, not actual biological. But this is why end-stage kidney disease is such a, you know, this is what they use in public health all the time. This is incident rates of end-stage kidney disease. You can see it's highest in the Pacific Islanders, Native Hawaiians, followed by Black Americans, and then Hispanics. Then it's lowest in people who, again, self-identify as white. And this is from 2000 to 2018. This is some of the newest stuff, like these are like 2024, but they always, it's like years behind. But you can see this is the adjusted incidence. The good news is that it has gone down some in Black Americans, which is great. And then you can see here, American Indians, it's gone down. It's been pretty steady in like whites and the Asian populations, but some improvements in end-stage kidney disease, at least incidence. And then we look at ethnicity, we kind of see the same thing. Non-Hispanic is, you know, it decreased a lot, but we've actually seen a big decrease in Hispanics in terms of end-stage kidney disease. So there's some movement, which is great, and probably newer drugs, different things we've done, but obviously you can still see there's wide differences between the curves. And despite a lower prevalence of CKD, Black Americans and Hispanic Americans have a higher prevalence of end-stage kidney disease. So this is stage 1 to 3, and this is like prevalence of end-stage kidney disease. A lot of this could be access to care when they're presenting, right? So they're not seeing them until they're end stage. There's a lot of different reasons that go that, but when they look at this and in NHANES and all these other things, there's this lower prevalence of the earlier stages. And we know if you're a Black American with kidney disease, you're much more likely to progress to end-stage kidney disease than white Americans, no matter what your GFR is. So even if they have a GFR greater than 60, 2 times more likely. When you get down to a GFR less than 15, you know, lots of people are going to progress, but they still have a 40% increase hazard of progressing compared to someone who is white, again, adjusting for other comorbidities. Now, what we end up seeing too is there's the reversal of the mortality rate in the general US population. So in the general population, people, again, self-identify as Black Americans have a higher risk of death than white Americans. But as soon as you get onto dialysis, white people have a much higher risk than Black people of dying. And they think part of this is, you know, is there other things involved potentially? A lot of it is we think, you know, when we see some of the Black Americans that are getting on dialysis, I'm like, yeah. So are they just going to be more likely to survive because they're getting on at 25 versus the white person who's getting on at, 50. And potentially that could be it, but there's things we don't know and we can't really explain this, and this has been shown in studies over and over again. There's no doubt this costs a ton of money. So if you think about, we spend $41 billion a year on just end-stage kidney disease. And then we start thinking about excess costs from disparities of at least 13 billion. And so there's a lot of money, like, could we eliminate some of this stuff, things could get better. So if people don't want to think about the health benefits, you could actually show them money. Some people only respond to money, as we've seen. So maybe this is a way to bring that back. So we'll talk about some of the factors that come here. There's no doubt there's a lot of risk factors that are higher in racial ethnic minority groups, and we do see some of that. So there's higher rates of diabetes, hypertension, glomerulonephritis, dietary factors, and then socioeconomic factors is probably one of the largest ones, and that no one ever likes to talk about. And in public health, we talk about this all the time. It's like SES is probably the biggest role. But again, you see this as the incidence of diabetes, and you can see it's highest. And again, Black Americans and Alaskan Natives and American Indians. And then hypertension, much, much higher. Like Hispanics and whites have been pretty similar, but obviously Blacks have a much higher rate of hypertension than the other ethnic and races. Now, this is blood pressure control. So this is interesting. This was from 2019, but unfortunately it still looks the same. So this is hypertension any stage. This is non-Hispanic white, non-Hispanic Blacks, Hispanics, and then kind of others. And so you can see obviously more hypertension in people who are Black. Then treatment eligible, meaning like, are you treating them? We start seeing like, well, how are we doing? Well, we're not doing great in anybody, right? So like, if you look at like the group that like, oh, maybe they do the best, like 50% are still not at goal with their blood pressure. But when we start looking at our racial ethnic minorities, it's much higher, that we're just not at goal for their blood pressure control. We did a study years ago where we looked at the primary care docs from here and from Denver Health. And we just started looking at, racial and ethnic differences in their hypertension care. Like, do they care for people differently by this? And it was funny because when we said, well, do you think the US healthcare system? Oh, definitely. Over 80% said yes. Like the US healthcare system definitely treats differently. Do they think UCH and Denver Health treat differently based on race ethnicity? The answer was yes. And then even in patients they treat, when people were honest, because this was anonymous, over 30% said, yeah, I probably do treat things differently. And then some of the open-ended was, well, maybe I start different medicines because this group might react better to that. And as I'll show you, this is still there. And this was from 2015. So, and this is even where we're at in, Colorado. There's more hypertensive, what we label end-stage kidney disease. This is hard because this is based on the 2728 that you guys will see once you're attending and you're signing these things. And a lot of times it's like the clerk who's filling it out. I was like, no, they don't have hypertensive kidney disease. They have like ankylosing vasculitis, but I'm like, you have to, but they'll put hypertension as a cause of end-stage kidney disease. So it's hard, but it's still more prevalent in those groups. Obviously, we know glomerulonephritis is more prevalent in certain racial ethnic groups. And then genetics. So everyone keeps saying we got to blame genetics. And there is no doubt APOL1 is there. It's present in people of Western African descent. It was protective against African sleeping sickness, right? Because it lyses trypanosomes. And genetic variants are there, but you need 2 variants to have disease. And so it is truly a primary cause of arterionephrosclerosis. And so they really were like, this is what's going to be there. So when they went back to the ASK trial and these big trials that had a lot of African Americans in them, they were looking at this and they were like, well, who progressed? And so if they had 0 copies or 1 copy, they didn't progress as much as the people who had 2 copies of this APOL1. And so it did definitely look like 2 copies, really your risk of progressing to end-stage kidney disease was much higher. And this is again, APOL1 no proteinuria, APOL1 high risk, no proteinuria. So again, proteinuria is a huge, distinguishing factor here too. But as soon as you had high risk with proteinuria, your risk of progressing was much quicker. And so again, it's like, there's like probably this 2-hit hypothesis. If you're more prone to this, 2 pathogenic strains itself, you're going to get stuff. And then, yeah.
For the last slide, the low risk versus high risk APOL1, does that mean one
Versus 2? Yeah. Yeah. So low risk would be 0 or 1, but it's like 1 copy. And they did that. But when they went back, only 25% of them had 2. This is in the big ASK trial, which was over 1,000 African Americans that were in this trial. So it really couldn't explain everything, because it's like, okay, if it's only present in 25%, that can explain why all of, their risk of progressing is so much higher. And so that's why it's like, there's gotta be other things, and that's, and I think that's where a lot of this comes in, these environmental stresses. And maybe modifying stuff and kind of leading to the development. And then that's where like SES comes in, because there's no doubt any disease you look at, any disease, morbidity, mortality rates are inversely related to SES. And so as your education, your job status and income increases, disease and death decrease. You guys see this in your patients, right? So for those of you who have clinic at Denver Health, you see a lot more than what you have when you have clinic at the university. And even at the university, you have some patients that are the Medicaid patients, and then you have your private pay patients, and it's sometimes like night and day different, right? You can like do a whole visit with that one person in no time. They're doing everything you tell them, they understand, and they know why they need to take their meds. So this is why SES probably plays this huge, huge role. And if you in a low SES, it's a 59% greater odds of having CKD, just if you're from lower SES. And again, many reasons, but this is where they adjust for insurance status and other things. So it's not just that. This is SES in women. So you can see here's low versus high SES. And it doesn't matter what race or ethnicity you look at. If they're low SES, they have a much higher rate of end-stage kidney disease than if they're high. And again, this is across all races. And we know, unfortunately, if you are Black or Hispanic in this country, you're more likely to live in poverty. And this is below poverty in 2019. As you can see, it's much higher in certain racial ethnic groups. They're more likely to be uninsured in a lot of these groups. We made some improvements in Colorado for certain groups, but I don't, in other states, but that may be going away in the next few years at least, which is unfortunate. But even like in populations who should have it, they're still underinsured, like American Indians, because the Indian Health Services, like I have a lot of these patients, and it's really hard to get them care from there when it should be easy, but it's like so many hoops to jump through. So I have a lot of dialysis patients that are part of tribes. It just takes a long time to get them access. So culture, I think this is stuff that we can learn, right? So what can we do? So like, you got to know what culture is, because culture plays like big role in forming attitudes to healthcare. So culture is truly, like, definition is the set of shared attitudes, values, and goals, right? So that could be, you could be talking about the culture of a racial ethnic group, you can be talking about a culture of something else, but it's like when everyone has this, but we have to remember that this will really form their attitudes to healthcare. And so a lot of people have healthcare beliefs, and you guys have all seen this, that conflict sometimes with Western medicine. They don't believe in this, they only want to do this. How many patients have you seen that are like, I'm only going to take all these herbal supplements, but I'm not going to take them for my blood pressure, and they'll take 30 other pills a day, but not the one pill that probably can help them. But like body size, right? Some cultures, body size being larger is absolutely acceptable. And yes, it can be associated with adverse things, but they don't always see it like that. Language barriers is huge. And so cultural competency is really critical. And of course, again, it's sad giving this talk now because this is all going away, that they no longer, this is why we had DEI things, to try to make sure when people are being cared for, they could be cared for people like them, because they feel more comfortable with that. But oh goodness, but yeah. And I think, you guys are all really young. You've probably heard of this Tuskegee syphilis study, and everyone hopefully does. If you've never read this book, it's incredibly depressing, but it's called Mama Might Be Better Off Dead. I had to read it when I was doing my public health. And it follows this family in Chicago about, all the stuff they have, very poor family trying to work through all of the healthcare system. And, this comes up over and over, like, they don't think doctors have their best interests at heart. And like, they refer back to the Tuskegee experiments, but we saw it in COVID. Like, it was really hard to get, especially Black Americans, to want to get the COVID vaccine. They're like, oh, they're testing it in us first, like they did with this, and they're probably giving us syphilis. They're going to give us COVID, see what happens. And it's stuff that like people don't understand. And this is a direct quote from that book, that, they could become unwitting subjects. And we have to remember that. And so it's hard, but if you can build that trust with your patients, so they actually trust you, that you do have their best interests, whether or not you have their same culture, sometimes things can go a lot better. I really like this. This is from Suzanne Nicholas, who I just love. She's an amazing researcher from UCLA, but they kind of came up with this socioeconomic deprivation in CKD. Where we know there's all these other things, whether it's segregation, discrimination, you're uninsured, all these different things kind of lead to these big risk factors, right? Low birth weight, obesity, diabetes, hypertension. It's been shown over and over, whether it's depression, there's all these different things, but they all can then lead to CKD and then end-stage kidney disease. So this is really where the socioeconomic stuff comes into play big time. And so is there other stuff? Yes, there's probably a lot of these socioeconomic depravity that are leading to epigenetic changes. Because there's always a two-hit. We've seen that for so many diseases. Like something's there, but then why doesn't everybody who has it something else? Is it going to be another gene? Maybe, but it's probably some kind of environmental. I mean, we see that with FSGS, right? If you have a copy of APOL1 and then you're unlucky to get FSGS, you have diabetes, you progress way quicker, right? Than if you didn't. So is it the second hit that you had one copy of APOL1, but then you got diabetes? And then things get worse. So lots of things that are there. And so the risk factors are, there's a lot of different things. What are the things that we could fix the easiest? Well, obviously socioeconomic and giving everyone access to healthcare would be the easiest one, and access to medicines. Because the other things are harder, but sometimes that would lead to less obesity and less other things and less uncontrolled diabetes, for example. Oh, the treatment of CKD, unfortunately, there's a lot of differences in treatment. This is, again, white patients are significantly more likely than Black patients to have achieve control of their hemoglobin A1C, their LDL, and their blood pressure. And again, after you adjust for all these other things. Now, you guys again are young. I realized today when Marco was like, why they didn't test the ARBs? And it was like, they weren't around in the 80s. So we had like AIDS and everything. Now, granted, I was a kid in the 80s, but like they didn't start, the ARBs came much later, but I thought that was really cute. I was like, oh, young. But this was a big problem. And this is still taught. Like I can't tell you guys have probably seen medical students who still bring up like, oh, the RAS inhibitors aren't as helpful in that. And I'm like, what are you talking about? Like, and it drives me nuts. But it's because studies before 2001 showed no improvement with ACE inhibitors in African Americans. But these were such small ones, they were not powered. They weren't like, there was no way you could draw this conclusion. And so they thought this probably limited the disproportionate burden, right? So it was like, start with an ACE inhibitor. They do the best with an ACE inhibitor. So someone's diabetic with proteinuria and they were getting an ACE. But the other person was getting, they were not getting the ACE, right? They were getting the calcium channel blocker. And this happened over and over until they actually did the ASK study. And it took that, and this came out in 2002. And lo and behold, the ones who got ramipril did much, much better, especially when you had any type of kidney disease. And whether they had proteinuric kidney disease, they did even better. But even the ones that didn't, when you have hypertensive renal disease, it's sort of what you want to do. And it was safe and it was effective. And so kind of going along with that, this is the people who saw a nephrologist prior to dialysis. We don't do good with anybody, right? When you see like how many people actually like, there's like 40%, 30% of people who never see us. And we see this all the time. But it is higher that, less people that have from certain ones, especially Hispanics and Blacks, are less likely to actually see us before they start dialysis. So they're not surprising. They're less likely to have an AVF if they're not seeing nephrology or someone to take care of that. And then they're less likely to get placed on the kidney transplant waiting list as well. This is within a year of dialysis initiation. So this is like now saying you're getting on dialysis. If you qualify for Medicare, you should get it, right? Most of them, once they're on dialysis, qualify for Medicaid. And here you go. They still within that year couldn't get it. Rules were different back then where, you had like, it was from the start of when now we can go back and retroactively put people from, you've been on dialysis 5 years, you get 5 years of waiting time. It used to not be like that. So if you're on dialysis 5 years and you just got on the list, your waiting time started then. So you already had those 5 years of dialysis. So think about how like their mortality risk was so high. So that was a good thing that's changed with transplant, but this is still a big issue. So not surprising, if you're less likely to get on the list, you're less likely to receive a transplant, but even the ones that are on the transplant list, they're less likely to receive one. And again, this is all donor types, much less likely to receive some live donors as well. Now, a lot of this becomes in referrals to transplant. So we know that Black patients are actually less likely to be referred for transplant evaluation. The average of studies is about 44% lower odds of referral. And when they look at this, they kept being, oh, it's gotta be the patient factors. And it is true, when you talk to patients, studies have actually found when they do like qualitative studies that Black patients with CKD that are on dialysis, they feel like they're healthier and they feel like they're, they just, do they not understand, but they feel like they have good health. They don't really understand what transplant is. They have more confidence of their prognosis. And then patient knowledge, and they were just, again, going through all dialysis units and saying, well, how much do you know about transplant? Like, do you know that it's benefit? Like, very simple questions. Only 21% of those of Black patients knew basic transplant knowledge questions. So again, lots of education thing and less likely to discuss with potential donors. So this kind of goes back. We see this with Hispanics as well. I mean, they try to do this here, the big ask, big give, the NKF, like I know Sixto, he goes, like Monica before him, like we go into the community and do all these things, trying to talk to them about how to talk to people about living donation, because again, it's just this distrust and like, well, I'm not gonna let you take my kidney or I'm not gonna donate it to somebody else. So it's hard. Now, we did this is what I did with a medical student a few years ago, because he was really interested in this. So we basically went and did surveys of all of our dialysis patients, because we're like, we can't be like that. We're referring everybody, and we weren't. And this was all of our dialysis units, the Denver Health ones and university ones, not the VA. I mean, some, VA patients who are sprinkled in our units, but these are all of our Fresenius units. And so, were we discussing it? Yeah, over 80% we were discussing it. Less than 50% had an evaluation, and then, down here, very few were listed. But when we start seeing the numbers, we did a, fairly good job talking to people about it. When we start getting down to the evaluations, and I don't know if we just ended up getting more Hispanics, like actually did the survey, but we were doing actually pretty good with that group. And this was kind of in the time we were transitioning when Dr. Grafales came, and we were doing a lot more things with the Spanish speaking patients. But when we started looking at like the reasons, most of like what we saw, this is Hispanics in the blue, the non-Hispanic black, and then green, and then this is the non-Hispanic whites. So the ones who weren't sure how to proceed were our racial ethnic minorities. They didn't understand the benefits. The white people did, the other ones did not understand the transplant process. It's interesting, none of them said they were scared, at least the Hispanics, but dialysis is not that bad. Not a single white person said that. But look at this, like non-Hispanic blacks, over 20% are like, it's not that bad, I can stay on this, right? I mean, like, it's just something that's like, what are we doing? And then the not referred by provider was really sad to see, like, why are we not referring them? And so there is this long-term thing that, again, from failed studies, that African Americans are more likely to have long-term graft failure, because older studies show that compared to whites, when they got a kidney, they're 1.8 times more likely to have the graft fail. And this wasn't due to HLA matching or SES, and so they said, oh, okay, what is it? But now with the newer immunosuppressive therapies, this is not the case. So again, this is all comers for Black patients in the US. So it's 1 year graft loss, this is 1990, and even in 2012, it was reduced significantly. And this is obviously 5-year, went from 50% to less than 30%, and it's even better now. So this is like big improvements just with better immunosuppression and actually giving it to people. There's no doubt this is probably more for patient provider communication, because they were found that even when patients desire transplant, discussions aren't occurring. So that happens. Qualitative study found that Black patients voicing their interest in transplant were listed in the chart as not interested. We have less preemptive transplant referrals and pre-dialysis CKD in these populations. And then sadly, only 41%, they did 254 dialysis centers. This was across the United States, and they sent out to all the docs, like nephrologists, not APPs, these are nephrologists, and gave them, questions about this, like referrals and how you feel comfortable. Only 41% felt knowledgeable to answer questions about transplant. And it's like, basic stuff, like, is transplant better than dialysis? Yes. Like, in all patients, yes. Like, but it was very basic. You did not have to be a transplant nephrologist to answer these. So it's very sad. Patients are no doubt, they're unaware of their listing status. I can't tell you how many of my patients go for their one eval and they're like, I'm on the transplant list. I'm like, no, we have to get all these tests, and then they have no idea. And this is what all the studies show. They just don't know. They don't know where they're at. They don't know when they become inactive. And when the transplant unit doesn't communicate well, which is what we see here, unfortunately, we don't get a lot of good communication. We don't know. And all of a sudden someone's inactive and they get a letter in English when they only speak Spanish that they're inactive, and they're like, I don't even know what this means. And then I'm like, oh, you missed some stress tests, like, we gotta do this, now we gotta start all over, and they make them restart the whole process, and so it's very frustrating. No doubt, just like we see for dialysis, if you're lower SES, you're less likely to get a kidney transplant. And this is so true. Like, I had a patient who had amyloid, and he was a younger guy, but high SES, you know, lawyer, very functional guy. He got himself a kidney, went to all the different places, and somebody transplanted him. He wasn't even out of his amyloid very, you know, very long. And but he was a great advocate for the whole community, and he did a lot of wonderful things, but you could just see the difference between somebody who had the means and could do it. It was like, I gave the referrals, he was there, he was done, whatever he needed to do, he had a list. And my other patients, I'm like, please, let me help drive you to over there, you know? And many transplant centers will do everything the same day now. And I've been begging them to do that here. They will for certain insurances, but not. So patient education level, again, more education you have, more likely you are to get wait lists, because you understand, you know, again, it's your health literacy is much higher. Like, it's better for me to get a transplant, so I'm gonna do what I need to do to get a transplant. And so we see that, and the disparities between the races actually disappears when you look at people that are like educated. Several studies have shown this, that there wasn't any statistical difference in the ones who've completed college, but we're talking about much more advanced education. And again, education level, but this is when it will decrease the racial disparities that we see. So now we'll talk about eliminating these. I don't even know where to go anymore. Like, I can just talk
Just
so
the word
much.
disparity, it doesn't exist.
They're just not there. The things we can do are probably this, right? At our patient provider things, we can make sure we're effectively communicating with our patients. We're providing them education. We're doing targeted intervention. We're making sure everybody's on an SGLT2. They're on their ACE and R. We're giving them GLP-1s if we can. Like, we're doing our care that we can give to reduce this. Community level, I mean, obviously I still do this a lot with the NKF. I'm on their medical advisory boards. I'm always out there in the community, you know, doing all this advocacy. It's going to be harder for the social and health justice. I think is what we have to call it. It's just going to be more probably community events. We'll see how NKF approaches this. I don't know. And then obviously the automated GFR reporting was huge. It took forever for me to get them to do this. I was like the most hated person at the university. I had like the chair of medicine calling me at night, and I was like, oh, this is bad, but it worked. And so, you know, you guys probably know the history of this, like University of Washington, the medical students said, wait, why did we have one GFR equation for Black people and one completely, you know, for everybody else all together? And it was based on the CKD epi study. They said, well, you know, and they studied people who, again, self-identified, and whether they even self-identified or it was the other person that just saw them and checked the box, like, oh, you look white, so I'm gonna check the box, right? That people that were Black had GFR levels 16% higher than people of other races. And they actually wrote in their findings that it's because they have higher muscle mass, but they actually didn't measure it. It was just, this is what we think, and kind of just became. So then it was like, oh, so we should obviously use the cystatin free. You know, if you can, the cystatin C based equation, you can combine the cystatin C and the creatinine. That works very well. That's probably the best one to do and combine both equations. If they correlate pretty well, you're probably fine and you can plug it into both. But if they're definitely discordant, I definitely use both. So if like my cystatin C comes back at 1.3, but my creatinine is 1.8, I use the combined one to kind of give me, I don't know which is right, but at least it's giving me a little bit better overall. But when we did this like Denver Health, so I was like, you know what, we need to do this here. So immediately I sent an email to Stu and I was like, if he forwards my email on Denver Health, like, cool, got it. It's changed like the next day. It was like that quick. It was like, yep, sounds good. And then the university, it was the lab guy, and he was like, I need to see this data. So I was like, oh, here's what, you know, and I knew the guys at University of Washington that had done this because I'd worked with their statisticians. And so they sent me all the stuff that they did. We sent it here and they're like, no, we don't believe this. And it was like this one guy that's like, I truly believe that this is different. And I was like, okay, you're a pathologist in the lab. And it became very, and so then I won't name names, but one of our previous fellows who's now on faculty, when they were residents, also got very involved and said, can we create like a list where people can sign that we want this change at the university? And I was like, yeah, so of course I had like higher ups involved, and it was more the residents letting them drive it, so. But then I got the phone call at like 9 o'clock at night and had to talk to the chair of medicine and the CEO and the CMO and how dare we do this? And I was like, change it. That was my response. I was a very not popular person for a while. But they find that, you know what? They never changed it. All they did is if you guys, I don't think you were here yet, but they would have where it would say with race correction, without. That's how they changed it.
Yeah.
So that was the compromise. Well, fine, we'll put it in there without it, but we're gonna leave it the other way. And then, but we'll put a caveat on there. So it literally on the UCH thing would say with race correction, without. And then you could choose which one you wanted. And then finally, once NKF and ASN came together and did it, that put the pressure when they said this needs to be nationwide, and UCH got rid of the with race correction on there, but. It was
Like that was just, yeah, like a couple of years ago, because I was here in residency when I remember the way they without coming out.
But it was right
Yeah.
on like that, yeah.
Yeah.
Mhm. Yeah, it was just a couple of years ago.
Yeah.
That's why it was like, yeah. But that's okay, it's what you have to do to make change. Now I'd probably get fired, so I guess I should be a few years ago, but I would still do it because that was the right thing to do. Because there's no doubt when we now look, they're getting sent to transplant sooner, they're getting on drugs sooner, maybe they're on drugs they shouldn't have been on sooner, like people changing them. Because like their GFR, like, you know, if you're falsely like, hey, their GFR looks a lot better. And then you're like, but does it? Like, is it really better? And then you're giving them something you shouldn't. And so this is one showing you just from the Crick study, when they said, well, what would it change? You increase the prevalence of CKD and, you know, obviously now in Black Americans, there's no doubt. But you can see that like when we start going, well, how long does it take to get to a GFR less than 20? And it would used to be 13.9 years, and then we're 12. So that's like 2 years quicker they can get on a transplant list. Right? I mean, that's a big difference for a patient. And so it was released late in 2021, the new actual equation. It was done by the same people who did CKD epi. They just went back through and did all this with this. And now this is the crude prevalence. This is the MDRD in 2006. This was blue is the CKD epi and the green is the new one. And yeah, you can see it definitely increased the prevalence of CKD in Black Americans compared, you know, I mean, obviously everybody's up a little bit, but that's just kind of what we ended up seeing when we look at that, the crude prevalence. So culturally competent clinics do reduce disparities. This is one of my favorite trials. I think this is so cool. This was the barber trial. So this was 78 predominantly Black barbershops in the South, and they had about 319 Black male patients who went to these barbershops. And they were randomized, and they just did the shops. Like, you know, it's almost like the pragmatic trial. So this barbershop got this one didn't. And so one had a clinical pharmacist-led intervention, and the other one was like an active control, where the pharmacist was there in the barbershop. And so basically, in the pharmacist one, the Black barbers encouraged them to meet with the pharmacists that were there. They said, hey, you're here cutting your hair. Why don't you go over there? You have hypertension, meet with them. And so the pharmacists initiated, they monitored, and they intensified this. Obviously, there was like physicians helping, you know, with this stuff. And the active control, the barbers encouraged lifestyle by saying, hey, you should see your doctor, you should do all this. And this huge, so this is intervention at baseline. And this is the intervention after 12 months. Look at the difference in their blood pressures. And this is the control. Maybe you have a few patients that did a little bit better, but it was a large and sustained decrease. And again, being at a place that they were comfortable, people they trusted. And this was huge. And this is obviously from hypertension. This was from 2019. But it was carried out in this trusted environment. And the intervention was team-based. There wasn't just one person trying to do this and it kind of shows now, is it sustainable? Who knows? We obviously did this with the Hispanic transplant clinic at UCH in 2018. This is when Dr. Grafal came, and the entire team was Spanish speaking, still is. And so we went back to look, and so we did a mixed method analysis from 406 Spanish speaking patients. We just focused on Spanish speaking only. Because we felt like some of the outcomes were probably different than the ones who also could speak English in terms of their ability to get through the healthcare system. And so we compared outcomes before the transplant clinic and then after. And what we saw was like during 2018 to 19, we had way more referrals in this group, like 76% increase in people who were actually being referred for transplant because it was so much easier. We could now in Epic put in their Hispanic transplant clinic or to Dr. Gopal's completely, and then they knew they were Spanish speaking. They've now since changed Epic to where you can like do that more, but you couldn't back then. And so it was really hard to get our patient. They could give us a number for the Spanish speakers to call that was actually answered by someone in Spanish. So they didn't call and have to listen to all the things in English, and they'd hang up before that. So it was huge. And then, granted, the transplanted number was small, but it was a decrease. But when we started, how many people were getting reviewed, like that actually made it through the transplant process, it was so much higher, 155% percentage increase. So it worked. And, we see this more and more. What did we do? Well, after we did our study, that was so depressing that we weren't referring everybody. Like, we kind of made it a blanketed thing, like everybody gets referred unless you have active malignancy, you have dementia, you live in a nursing home, like, things that are like the automatic disqualifiers. But otherwise, I send everybody because I know they're probably not going to be a candidate for other reasons. For them to hear that from somebody else than me. Because me as their doctor every time I'd be like, well, you just don't want me to, and that trust thing. And I'm like, well, let's see. Then I'll even refer them to like Porter after that and send them for a second opinion. Some I'll send out of state if I really feel strongly they need to get a transplant, and I'll call and fight with the transplant doc somewhere. And usually I can get them. Usually Mayo will take them. But and we've really done a good job of this. The social workers have. I mean, it's a CMS quality thing, so you guys will see that. Like if you're in dialysis units, you have to do about how much people have had transplant education. But to me, it's like I have the same patient, and every time he's like, "I know you're gonna ask me about transplant." I'm like, "I am," because one day you're gonna tell me yes, that I can refer you, and we talk about every month. And he finally told me, it was years, like every time I saw him, and he's like, "I know your last question is gonna be about transplant docs." And then finally one day he was like, I saw so-and-so, like another younger African-American man who's got a transplant. And then he was like, what, if he can get one, I probably could too. So now you can refer me. But it took me like but he knew I wasn't gonna let up, because I was like, I'm just asking if you're interested, go see what it's about. So we also put every material into the patient's language. Initially, we only had English and Spanish. The dialysis unit again got very mad at me, but now they use them nationwide. So in my unit where I have 12 different languages, they all get it in their own language. Except for Navajo, because we could not find something I could translate Navajo to written language. So that's the hard one. But his son speaks it. So we can send home the materials in English for the son. But yeah, and then we partner with the Kidney Foundation, and obviously we're educating on disparities in this stuff too. So I think, we can solve these problems. We can't solve the healthcare things that are happening, but I think like on our own individual level, there's things that we can do. And I just encourage everybody, like, it's hard. It's hard to get trust with these populations. I mean, I see it because like I go into the communities and I'm very well aware. I'm like the white woman walking into this community where I go to, but I bring people with me that are similar. We encourage the patients. We do a lot of peer stuff at my unit. So when someone gets transplanted, I have them come back and talk to all the patients. They all become friends. Like a lot of people, I know we push home, but some people, this is their only interaction with people, but then they'll see it. And some of them will start to really improve. Like, what do I have to do to get a transplant now? This works very well at Denver Health, where I had a lot of younger ones. And I think, Seth and Jamie still do that there because it's just the population. And now at my Northeast, when we get a lot of those patients too. It's harder when they're completely undocumented. We have to get them some insurance, and then you have to get the American Kidney Fund to pay their premiums and do all this stuff. And then they still won't even see them in the transplant center unless they have like $10,000 to $15,000 in their bank account that they can show. And so a lot of them can't get this stuff, but we push it really hard. And so that's what I encourage you guys to do. Like, can you do stuff on the big scale? I don't know anymore. I don't know what's gonna happen. We're trying, but I think like there's things you can do in your practice and wherever you're at, because like, you can't change what your race or ethnicity is. And you're gonna care for people from all different ones. And so if you can just sit there and talk with them and really, and there's gonna be some that no matter what you say, they'll never trust you. They're not gonna listen. But a lot of times, like, and I learned this like at and I still do it now with my dialysis patients. Well, why aren't you taking this? And a lot of times it's like, because I can't afford it. because I had to pay for my electricity. And, oh, well, we can get you some help with your electricity. I didn't know that. Let's talk to the social worker. And then we get them help paying their bills, so then they can actually pay their medicine. Or I do, lots of people are on Medicaid and they'll cover some things, and the other one, and I do so much Good RX, so much Mark Cuban's pharmacy, so much call around to Walmart and figure, does it take me a long time? Yes. I have to go to the patient while I'm there and say, which one of these Walmarts is where you live? And I pull it up on the computer, we find it, so I can send it to that one, so then they pay $4 for 90 days. And so there's a lot of like little things like that I think it takes a lot of work. So it's kind of, it depends on where you're practicing. Like you'll probably get a lot of that with, being kind of just the population. Are you gonna be more on the Thornton, do you know?
It'll be our bad.
Yeah, so you'll have a lot, yeah. So you're gonna have a lot of, you're gonna have a bunch that are, but you're not gonna have the like Lone Tree,
Yeah.
Highlands Ranch.
Yeah.
I mean, they try to put those dialysis units there and they're like, nobody comes. I'm like,
Yeah.
like there's $1 million houses all around, like those people get transplants, like they're, they're not on dialysis, so you'll probably. But if you need like help with any of those things that we've done, just let us know, cause like we've done a lot of that. And I don't know how it'll be. I mean, I would assume you'll have quite a bit where you're going too, I would think. Or
Yeah.
that, I'm just curious,
So just like with the Hartford
Yeah,
population, I think a lot of different immigrant populations
Okay.
there, but I think a lot are from like the like Southern Creole, like Bahamas, Mediterranean.
so you'll have, so you'll probably. And it's just kind of seeing what's available, seeing what's out there in your community, what you can do. That's what we can do on an individual level, and then you can get your healthcare system. There's like a whole bunch of groups that I didn't talk about, right? So like women are much less likely. We started about the LGBTQT people, I mean, my goodness, we don't even know what equations to use for their GFR. And we had this happen years ago where I had a patient in clinic and I was like, okay, well, and he had, obviously gone through a transformation, but I was like, if I use your other, your GFR from when you were a woman, you'd be on the transplant list. So do I use it or not? And transplant, they didn't know either, so they actually allowed that. And we got it transplanted, which was great. But I think it's hard, and there's lots of stuff happening in that area, but I don't know. They canceled pretty much all those grants here for that population, and it's very sad because I work closely with a lot of those researchers. I don't know. So I always say, do whatever's best for your patient. I mean, now sometimes like the patient may be like, no, I definitely don't want you to say what I was before, for these reasons. But then if you can be like, well, but I can get you through the system faster, maybe, but it's, that would be a very, tough conversation you have to have with somebody to figure it out.
I have a hard time with like the age-based, like U25 equation, sending patients based on that equation to transplant, because they'll say that that's not the equation, even though the EGFR is lower, so they don't actually qualify.
I know.
That's been my hurdle.
Just put them on steroids and get a cyst see if it's
The hard part is like the transplant centers have their own particular ones, but usually they'll accept it like. I don't know, okay, maybe I game the system. I should make a computer. Like if I have a patient who gets AKI, and then one of my CKD, and they get one time their GFR falls to the 20, I absolutely refer them. Then they go through the whole thing and now they're like, well, they're too healthy, but they're actually listed. They're getting time, they're just inactive because they're too healthy at the moment, but I do that. If you have someone who gets hospitalization and their GFR drops, say, oh, transplant, GFR wins. Yeah, I mean, that's what I don't know what everybody else does, but that's what I do. Maybe I game the system more than I'm supposed to, but you have to. I feel like there's no other way around it. Like the system is not set up to help people. And it's not set up to get people through this. If it was, they could go show up at the university for their transplant thing, get their echo, get their stress test, like all in one day. And then, yeah, maybe you need a cath and fine, we'll do that on a different day. But if you could get everything else in your mammogram, you're like all, whatever you need, and colonoscopies, yes, I get it, it has to be on a different day. But that's what takes forever. And I can't tell you how long it takes us to get the patients. And my poor, nursing staff goes above and beyond where like we arrange rides for the people to get there, so they don't have transportation. And they're not supposed to, but we do it. And, and if you had a navigator, oh, that's why every navigator study is positive. that's why like NIH is like, stop doing navigator studies. We all know the concept. Like, they're like, we don't need that. The problem is no one will pay for it. Interestingly, transplant has been a way that they've got it, you know, with navigators. And I don't know if it's just because they bring in so much money to the health system that they're like, cool, you want some navigators, here they are, but we cannot get that for kidney disease. And the dialysis companies, you're like, and there's always that thought of, and it's sad, because you look like the big dialysis organizations, why people aren't being pushed to transplant more. And they say it's because they're losing money. Most of the time, like, that's not the medical director, like, it's truly more system things. That might be true for some places, but like, the majority of us are like, we want to get you off dialysis and get you to transplant, especially my young ones. And I will advocate for my switch of shifts. If it's like I'm working and I can't do that, I'm like, well, we're moving your shifts because you got to come here. I make the nurses go back in, like if their transportation was late or had to pick them up early, and so they had to come off dialysis, I make them go back in and change that, because otherwise they look at that for transplant and they're like, you cut your time.
Mm.
And they showed up an hour late because their transportation didn't show up, you know, and what are you gonna do? And it all depends on the people documenting it, the techs and the nurses, and if they're busy, they're like, showed up late. Not like due to transportation out of the patient's control. There was one guy who was always late because he had to take his kids to school and nobody had asked him, so he switched to my unit and I was like, okay, well, why are you all, and he's like, well, I take my kids to school. I was like, well, why don't we just put you on to after your kids, you drop them off, and he was like, what? And I was like, yeah, let's just move you, like, what time do you get done with the kids? And so, and I had to ask another patient if they would switch with him, because of course, oh, we don't have the slots. Patient was like, sure, I'm retired, what do I have to do? Totally swap. And so there's like, again, little things you can do, but, you know, they have to trust you first, and that takes time. But I joke around with a lot of my patients. I mean, my patients know I celebrate their little wins. If their FOS went from like 12 to 9, I'm like, you did awesome. And they get all excited and I give them like gold stars on all these things. Because that's a huge difference. If they've been over 10 for like months and I got them under there finally, because they finally, yeah, medicine, you know, like, those are kind of things you can do. And then they start trusting you more with what you say. But it takes, I don't know. I probably spend more time than I should at the unit. I could be done quicker, but. Part of me always wanted to be a PCP, but I didn't want to be a PCP because I don't want to deal with like other things. I think maybe that's where part of that comes from, but yeah, so. That's it. I'm gonna stop there. So now you guys. Yeah, I just get more depressed when I talk about it. Our group. I was on the Department of Medicine Diversity. And we had a big committee, and our committee is like, no more, we can't call ourselves that. I don't even know what we call ourselves now. Now we meet like off campus. I mean, that's. Doing like stuff like, that's shady, but we're not,
Yeah.
but. When they're reviewing us.
Like the-
God bless America. You guys lunch should be coming soon, huh? Who's next? Oh, Ruth.
Crazy is. Apparently this show's gonna come out, it's a conclave now. I saw a post, which was like about using a new phone. Someone was like, the marketing for the show's crazy. The marketing for this show is crazy, because the Pope just died.
Wow, the timing.
Mhm. Also, right after meeting JD Vance, which I thought was funny, there was a ton of memes of like, the Pope met the devil and just died. Yeah, that's fine. Group project, it's like, it's actually.